This is the cheat sheet. All right. So this has a little bit of everything on it. So let's just chat, shall we?
Yes.
All right. So when they say urination, they could also say micturition and voiding. Those all mean the same thing. Okay. Aging effects. So this goes into geriatrics as well, right? Okay. Their urine is not as concentrated. Okay. So one of the job of the kidneys is to concentrate urine, right? It's supposed to analyze your blood pressure and determine how much water it needs to let out. Okay. And that decreases your blood pressure. In elderly clients, their kidneys aren't very good at doing that because their kidneys are older, right? And so they're not able to concentrate urine, which means they lose a lot more water. So that's a reason why adults or older adults are much more likely to get dehydrated very quickly. Okay. Because when they pee, it's just a lot more dilute because their kidneys can't concentrate urine anymore. Okay.
But I thought when urine was dilute, when urine was real concentrated, that means dehydration.
It does. That means they're already dehydrated, right? But when they're peeing out a bunch of water, that puts them at risk for dehydration, right? Because they're peeing out mostly water instead of being able to hold that in, right? So our RAS system is the system that constantly analyzes our blood pressure. Okay. It's called RAS. All right. And you don't have to know all of the patho behind it. I'm just explaining it because you understand. So the RAS system is there's these little things inside all of our blood vessels called baroreceptors. And they're like little fingers that constantly assess what is your blood pressure? What is your blood pressure? When it goes lower, it tells your kidneys to release some hormones. And those hormones will keep your water in. It tells your body, oh, our blood pressure's low and we need to keep water in. So concentrate the urine a little bit more and don't let go of water. Now, in elderly clients, that RAS system still works, but it doesn't get the message that you're supposed to concentrate urine. Okay. So it sends the signal to the kidneys, but the kidneys are older and they're just not able to concentrate urine well. And so they let out a lot more water than they should.
Is that just a normal part of aging?
Yes. There's nothing you can do about that. So one of the indicators of kidney function is called a GFR. All right. It's a glomerular filtration rate, right? It tells us how well you're able to filter urine. Now, normal is over 125. That's for pretty much everybody. But as you age, your GFR goes down and your kidneys, they just get older and more tired, right? And they're not able to filter urine as well. So around age 65, your GFR is going to be around 65, which is half, half of what it was in a older or in an adult patient. I know, and so they don't concentrate urine well, so they're at high risk of dehydration. Right. The second thing with aging is they usually get up to pee a lot at night because they can't concentrate urine very well. They have more urine, right? And so it makes it difficult to hold overnight time. Okay. The second reason why they can have nocturia in men is prostate problems. Yeah. They get up all night to do that. So noct, like think of like nocturnal animals, means night, and then urea is pee. They pee at night. So all of these terms you're going to be able to put together, right? Okay. So that's why I'm teaching you the prefix and suffix. All right. They really will. Yes. As you go on. Because inevitably on your exams, you're going to get words you've never heard of. But if you know prefixes and suffixes, then you can put those words together and be like, oh, I know what they're talking about. Right. All right. The third thing about aging is the bladder tone decreases. Okay. We're up here at the top. So how the bladder works is it gets filled with urine and it stretches. Those stretching activates nerves inside the bladder that communicate with your brain that tell you, I need to pee, right? So in aging, their tone is not as good, right? And tone is like the muscle tone, right? And so since the tone, it doesn't get to fill up and stretch and do all of that, it just kind of sits there a little bit. And so they may continually feel like they need to go over and over and over again because it doesn't stretch, open, activate, and then let go.
It just doesn't stretch as much.
No, and it's kind of they have like a floppy bladder. Okay. So there's not as much tone, so it doesn't get to fill. It just kind of sits there. So it may also dribble urine, which can contribute to incontinence. Okay. The last thing about one of the other things about aging is they have a decrease in the contractilities. That's how well the bladder is able to squeeze, right? So bladder fills with urine, activates the nerves, tell the brain you have to go. And then when you release that, you tell your body like we're on the toilet, right? It squeezes really hard, okay, to get rid of all your urine. That's normal. But in aging, they don't have as good of the contractility. So it may fill a little bit, right? Kind of activate. And then when they pee, it just goes like this. So it leaves urine inside the bladder even after they void. Okay.
Is that why I've heard that you're supposed to like lean forward?
Well, after they pee, you're supposed to tell them to bear down as if they're having a bowel movement, and that will push the rest of the urine out. Okay. Now leaning forward can help in some people. Sometimes we'll also push gently on the bladder to help release the last of it. So there's lots of things we can do to get rid of that. But because of the decreased contractility, they get urinary retention. So the urine just sits in there. Okay. Oh, your risk of UTIs is huge, right? Because there's urinary stasis, and any pee that sits in there over a period of time is going to get infected, right? So that's why elderly clients are at risk of dehydration and UTI. Make sense? All right, mobility issues. So this can lead to incontinence, and that's just because they can't get to the toilet fast enough, right?
Yeah.
Because if the tone is not very good, then by the time their brain gets a message, you have to go, I only have a few seconds to get there. And if I use a cane or a walker or a wheelchair, you may not be able to make it there on time. That's called functional incontinence. Like, I have the need to go, I can hold it as long as I can, but I functionally cannot get to the toilet, and so I may have an accident. Okay. All right, now let's talk about women right here in the middle. So in women, we know they have a shorter urethra, right? And the anus is very close to the vaginal opening and the urethral opening, so the risk of UTIs is much higher, okay? There's also a decreased bladder tone after childbirth because babies stretch out everything we've got, right? And it can weaken the pelvic floor, and because of that, you may have decreased bladder tone. So a lot of women after childbirth have stress incontinence where they laugh or they sneeze or whatever and they pee, right? Okay.
That's me.
My daughter laughs all the time because I make jokes about that when she scares me. You know, kids love to scare you. And I'm like, oh, I think I peed a little. She's like, oh my God. It's like the funniest thing, you know? And you're like, please don't, please don't, please don't.
Stop,
All right. And then atrophy. So A means
oh, A is like it's like shrinking.
without. Yes. So A will always mean without. And then trophy is usually in the size of the muscle. So bladder atrophy, size or a muscle. So like if somebody has like, but it usually means muscle size, right? So if someone has like muscular atrophy, you've seen people in wheelchairs that have very thin legs because they didn't use them, right? So that's A without, trophy, muscle size. Okay. So in bladder atrophy, that usually happens after menopause because menopause, you don't produce as much estrogen, right? And estrogen is a bone builder, right? And estrogen is a what we call a tissue plumper, right? It gives you boobs and hips and those kind of things, right? And so they can have bladder atrophy after menopause, which can make incontinence more likely as well. And then stress incontinence, that's what I was telling you about, where you laugh or you sneeze. They say like it's a stress, you know, like you sneeze, that's a stress on your bladder. No, but I guess they're saying it's like stress on the bladder because you vasovagal when you laugh or you sneeze.
Because when you say stress, it sounds like something negative.
Right, like somebody stressed you out and you just peed yourself, right? But it's stress on your bladder because when you're laughing or sneezing or whatever, you're vasovagaling. That's the pushing movement, right? And so even though you're not trying to like push, that's what happens. Yes, that's what happens. And so for everything, okay, for everything on this exam, you're going to pick to encourage Kegels. Okay. And you know what Kegels are?
Yes.
Okay. And that will help to build the pelvic floor. Now, pelvic floor rehabilitation is a brand new, like huge market right now because they're actually realizing like a lot of women suffer from this and that it's been showed for a long time because that's normal. That's normal. And people are like, it's not normal for you to pee yourself all the time, right? So there is a whole new market, okay, of doctors and physical therapists who are studying pelvic floor rehabilitation and offer that.
In that area?
Oh, yes.
Really?
Oh, yes.
Okay,
It's a big market.
names, then I need one.
Oh, yeah, for sure, for sure.
I mean, honestly.
Yeah, okay, yeah, absolutely. Do that.
Yeah.
Because it isn't supposed to happen, right? And there are ways that we can fix it, you know.
Well, that's good because,
But for, you know, forever they've always said problems with women are normal, you know.
Right, okay, well, that's just a normal part of it.
But it doesn't have to be.
Deal with it.
Yeah,
So
it doesn't
there's
have to
a way
be.
fix it. Oh,
Yeah,
thank
for sure.
God.
For sure. I'll send it to you. Okay, so right over here, urine output. Now, this is going to be on all tests in some kind of way for all of the rest of nursing school. When we're assessing urine output in a patient, it needs to be at least 30 mLs per hour. That's the minimum in order to say that they are hydrated.
1 ounce.
Yeah, but at least per hour. Yes. So I wouldn't do that off of like 1 hour. I would look over the last 4 hours and see like, oh, he's only peed out 80 mLs in the last 4 hours. He either needs fluids or something. He's not peeing out enough. Yeah. Yeah. Fluid intake, we recommend at least 2 to 3 liters per day. That is for every client for all of time, unless I specifically say don't do that. Like,
I was reading like for older people, make sure it's like a minimum of 1.5 liters.
I mean, that would be the very minimum, but especially since elderly clients lose so much water, 2 is pretty normal.
Okay.
And anybody that needs extra fluid, higher to 3. It's 8 glasses. Yeah. 8 ounce glasses. All right, labs to know. And there is a video on my YouTube channel for urinary labs. So I would recommend you doing that. It goes into much more detail than I'm going to go into today. But it's called Decoding Lab Values, Urinary Labs. Okay, and it'll go through all of the, and I think it'd be great for you because it goes all through the urinalysis and every lab that we do for kidneys. So I think it'd be really helpful. But this is just a crash course. So we'll do the BUN and creatinine are waste products the kidney's supposed to get rid of. Okay. They exist in our blood. The BUN is a byproduct of our protein breakdown. So as we eat proteins and, just natural protein functions in our body, as they break down, they produce waste, right? And that goes into our blood. It sends it to the kidneys, and the kidneys supposed to pee out that waste, okay? And then creatinine is another waste byproduct, but it's a byproduct of muscle breakdown. So as we work out or we walk here and there, or what have you, it produces a waste product, right? Muscle. And BUN is protein. Right. And so both of those are natural processes our body goes through, right? And the waste products then go to the kidney to be excreted because we don't need waste in our body. So in our kidney patients, like if they have chronic kidney disease or renal failure or something like that, the BUN and creatinine will increase because the kidneys are broken, they're damaged, and they're not able to get rid of that waste product. So when I say, hey, we need to run kidney functions, what the doctor will mean or what I mean is BUN, creatinine, and then we're also going to do a GFR. Those 3 blood tests tell me how well your kidneys are doing. Okay. Yeah, the GFR is that glomerular filtration rate we talked about. Remember, normal is 125. Okay. If you're a not an older adult, if you're not over 65. Yeah, go look at yours. You're like, oh, now I need to know. Yeah, for sure. All right, and then USG is the urine specific gravity. Okay.
Yeah.
So
I remember you mentioning it.
Yeah, this one's important. You'll have it on lots of different tests in lots of different ways. So the normal urine what urine specific gravity is basically how thick or how viscous your urine is. We're right here under labs. So a normal USG is, or urine specific gravity, is 1.010 to 1.035. Now, the specific gravity of water, just plain water, if I tested that, it would be 1, just 1. Okay. So the further away from 1 it is, the more thicker, the more concentrated it is, because that's the further away it is from water. Okay. So if somebody had a urine specific gravity of 1.040, whoa, that's thick and that's viscous urine. And it could be thick and viscous because it either has less water in it or it has other junk in it. Like maybe it has bacteria or it has glucose or it has protein or blood. Something made it junky. Okay. So normally we want our patient to be within 1.010 to 1.035. Okay. And we want the pH to be between 5 and 6 because we know urine is acidic. Well, for urine, yes. Because one of the kidney's jobs is to get rid of acid in your body, right? The kidneys are one of the acid-base balance systems in your body. There's lungs and there's kidneys. So the kidney's job is to get rid of excess acid. So we would expect that the urine would be acidic because that's the kidney's job, right? All right. Do we understand the basics of the labs? And then make yourself a note to go back to YouTube and to watch that Decoding Lab Values so you can get more information on those. I also go fully into the urinalysis.
Okay. Thank you.
Okay.
The USG.
Urine specific gravity. That's right.
So
water is 1. So the further away from 1 you are, the further away from water you are. Yeah. So the thicker and more viscous. Okay. Any questions?
So really, then nobody should be 1.0.
No, if it's 1.0, you're peeing out straight water and something is wrong because you're supposed to have some concentration of your urine. Otherwise, you're going to get very dehydrated.
Wait, what if it's going the other way?
Which way? The highway?
Below. Like, what, can it go under?
No, because water is, that's all you can pee out is water.
Okay.
Yeah. Okay. All right. Now let's go right here to your terms. Okay. So A means without, or you can also see AN. That also means without. And then urea means urine. No urine. So this hardly ever happens that you have literally little to no pee. Okay. Like your body's going to produce something unless you're in like 100% kidney failure. So be careful picking anuria on an exam unless they really give you a number. Okay. Because people are peeing out something, So Yeah, less than that's nothing. So anuria is less than 50 in 24 hours, which is your kidneys are broken. You need dialysis at that point. Like that nothing's happening.
Yeah.
All right, and then dysuria. What does dys mean? Think like function, like dysfunction, or like so.
Okay,
Dys just means there's something wrong. That's all it means.
Dysfunction.
So dys means there's something wrong. Uria means with the urine. So dysuria actually means that there's usually pain or some kind of uncomfortable feeling upon urination. Okay. Yeah, dys is there's something wrong. So think of like even like DIS means the same thing. So like disease, there's something wrong with you, right?
Okay.
So dys just means there's something wrong. You have a dysfunction, right?
Yeah,
there's something wrong with your function.
Yeah,
Mhm.
okay.
All right, glucosuria. Glucose means sugar, urea.
Sugar
So glucosuria is glucose in the urine, usually with our diabetic patients, right? Because your kidneys should not be getting rid of any glucose. That's not their job. When your blood sugar gets over 250, which is very high, right? Normal blood glucose is 60 to 100. Your kidneys will be like, I will help you out and I'll spill some of this glucose. But it's very hard for them to do that because glucose molecules are very large, right? And your glomeruli are small. And so it can cause kidney damage. That's why most patients with diabetes will end up in chronic kidney disease inevitably.
Really?
Yes, because their blood is more thick, more viscous because of the extra sugar, and they're asking the kidneys to consistently spill glucose, which ends up ruining your kidneys. Yeah. All right, and then you've got nocturia. We already talked about that one. Nighttime urination. Oliguria. So what does olig mean? I can't think of any word that even has olig except for medical words. So olig means like small or little. Okay, small or little. And so oliguria means that's it. Okay, so that's urine output of less than 424 hours. Still much less than 30 an hour. Yeah. Yeah, anuria is really bad. Okay. All right, then we've got pyuria. So well, poly is, but this one's pyuria. Oh, sorry, I missed polyuria. You're right. Polyuria. Sorry, I missed that one. I don't have my glasses on. Poly, yes, means many, and urea means, so that's, you're peeing a lot. Now that can put you at risk of dehydration. Yes, yes. And then pyuria, pie can sometimes mean pus. So that's pus in the urine. Obviously, you'd have a UTI because that's not supposed to happen. Okay. And then urinary incontinence means you have accidents. And then we'll talk about the different types of incontinence because they like to test on that. Okay. All right. So in the middle right here, I did just write down the diagnostic test. I actually ended up doing an entire sheet on these. I changed my mind. Okay. So this is just for the cheat sheet, and we will talk about each one of these in just a bit. I have a whole handout for it. Okay. All right, urine color changes. So what, now urine color changes, we do not panic about. They are not reportable unless you see like frank blood or like blood clots or something, because there's so many things that can change the color of your urine. What you drink, what you eat, your different medicines. Okay. So there's hardly ever a time you're going to report something, a urine color change. And I mean, if it's frank blood and you weren't expecting that, then yes. Okay. But any other color changes, I'm like, oh yeah, it's probably from a medicine or something. Brown, if they already had a UTI, I would expect that, right? So I wouldn't report that, right? If it was brown all of a sudden, or if the patient has liver disease, you can see brown urine. So it'd have to be something that I did not expect. Okay, like let's say I have an elderly client that's in the hospital for dehydration. That's what they were there for, right? And all of a sudden they spiked a fever and I see brown urine. Now I would report that because maybe they have a UTI and I would not expect that, right? Yeah, because it's yeah, you could have red. Red is usually more kidney, right? So if they have like a lot of blood, then that usually happens more from a kidney infection than it does from like a bladder infection. Yeah. A really bad one? Yeah, yeah. So most of the time, like, I'm not panicking about a urine color change unless it's, I mean, blood in any body fluid. Yes, I would report. But any other color, we don't really panic. Right. All right. If they're on anticoags, you may see it red or pink, and that's because they may be bleeding. Right. Now that I would report because I don't want their kidneys to be bleeding when they're on blood thinners. Okay. Phenazopyridine is a medication that is over the counter. You've probably seen it before. It's called AZO. Okay. Everybody's taken this at some point. Yeah. It is a urinary analgesic, so it just makes it not burn when you pee, but it does turn the urine a orange color. Okay. So if a patient has a UTI, you have to tell them they need to come and do a urine specimen before they take the AZO, or it will dye it. Yeah, it messes it up completely. And then B vitamins. If you take B vitamins, that turns everything, your pee bright yellow, like neon yellow. Okay. Wouldn't report that because normal. Yeah, I would expect that. Yep. So if you take like a B vitamin complex or something, you'll see it come out in the urine. 100%. Okay. And then, yeah, B is yellow. And then levodopa is a medicine that we give for Parkinson's, and it turns the urine brown or black.
That's going to be on our exam for geriatrics.
Oh, on Parkinson's?
The levodopa and that
Carbidopa. Yeah, levodopa,
like
carbidopa.
It's like, because the carbo one, like, takes care of the side effects or something.
Yes, the carbidopa decreases the side effects of levodopa, and it makes it work better. Yep. And then, so levodopa will turn it brown or black, not reportable because we already know that that was coming.
Oh, levodopa makes it black.
Yep.
Oh,
okay. All right, and then we're going to go right here, this purple part right here. If you're collecting urine from infants or children, obviously that can be difficult. Okay. So we do have a couple options though. If they are old enough to sit on the toilet, and they don't even have to be really potty trained, we can just sit them on the toilet. We can use that little potty hat. Let me show you. Yeah, I'll show you what it looks like. It looks like a sort of like a bigger bedpan. And you put it inside the toilet. The kid doesn't even have to see it, because sometimes when kids see something that they have to pee, and they panic because they're like, that's the weirdest thing I've ever heard in my entire life, right? You've seen these before. You should know what's called this probably. Let me show you I really need to go get my glasses. Okay. One of these. Have you seen one? Yeah. So that's a little potty hat. You stick it inside the toilet, and then you can just put them on the toilet, and they won't know any different. Okay. We can collect it that way. That's a potty hat. You can also place a U bag. These are challenging because we're trying to collect urine, but you got to think these are like little bitty, like infants, right? And so in infants, obviously I can't sit an infant on a toilet. So I will put on something called a U bag. Now they can be real tricky. For boys, it's a little easier because it's a little bag that you put all the way around the penis and the testicles. So that's not that big of a deal. But for girls, it can be challenging because even if you put a bag on, it can seep down the back or whatever. So, and these can be a little harder. But let me show you what it looks like. The only thing is they're dirty. Like, I mean, they're not a very clean way to catch urine because it's still sitting in the diaper, right? It looks like this. So you can see like this little part you're going to put around their private area. And then then you just put the diaper back on, and then you just let them, I usually have them feed. I'll say mom feed baby because usually they'll pee when they feed. And then you can collect it from the U bag. Okay. But this is a dirty specimen, right? So if I'm looking for a UTI, I may or may not use a U bag because if they poop at the same time, which babies do, some of that can get in the bag, So you got to use your discretion as far as what you're looking for and, what you think you ought to do. But that is an option. Now, if I'm collecting something like protein or blood, if that's what I need to look for in the urinalysis, then a U bag is perfectly fine. But if you're looking for bacteria, it is going to be a contaminated specimen. Yeah, because it's sitting in their diaper, no matter how good you clean, All right, so that's an option. That's the U bag. Now we can also use cotton balls. We'll have the baby in a diaper, and then you take like a whole bunch of cotton balls and just shove it in the diaper and then put it back. Now, I can only use that if I'm collecting for protein, specific gravity, blood, something like that. But if I'm looking to collect for a UTI, I would not use that because it's obviously going to be very dirty. It's inside a diaper. They can poop on it, whatever. But if I'm looking for anything else in the urinalysis, that's a good option to use. And you can just squeeze the cotton balls out over the little urinalysis. Okay.
So you just squeeze them out. Okay.
On the little, do you know what urinalysis looks like?
Is it like, is it a stick? It's a stick. I mean,
but if I'm looking for UTI, obviously I need like a sterile specimen, so that would not be a very good option.
But how can you get a sterile specimen of urine? Because doesn't it become contaminated once it leaves the body?
Unless you straight cath them. Because if you straight cath them, you're going right into the bladder.
Okay. Okay. So once it comes out,
if it hits the skin, it's not sterile anymore. But you can stick a tube all the way into the bladder and get sterile urine. I don't know where it went.
Is that what they do?
Yeah, that's how we'll straight cath somebody. I'll look during the break, so I don't waste too much of their time. But I know I have some somewhere. I just had the students do one the other day, so they're around here somewhere. Okay. So we talked about cotton balls. Now, if I want an actually sterile specimen, then I would do a straight cath. Okay. This one's
Mm-hmm.
tricky too. I will only do this on infants, like 1 year or less. And the reason why is very traumatic for the baby. Okay. You have to hold their legs open, right? Which is traumatic anyway. They don't know what's going on. I mean, that feels very, ugh.
Yeah.
And then you have to open the labia, of course. You have to clean it, and then you stick a tube in it. It hurts.
Oh,
And so you're holding them down, putting something in between their
oh.
legs. Like it can be very traumatic. So I only do it in like little infants that I know will not remember it, and I make sure
Yeah.
that I have somebody very skilled that can do it really quickly. Okay.
Yeah.
I've seen some doctors order a straight cloth on like a 3 or 4 year old, and I'm like, no, that is incredibly traumatic, and I would never do that.
Because that's
Never do
something
that.
that will probably stick.
I mean, to a child, I can imagine that feels very like sexual assault to you, because like somebody's holding their legs down and putting something between their legs,
Yeah.
and they
Yeah.
don't know the
Yeah.
difference,
Right.
and it probably, feels
Yeah.
horrible. So I won't do it, but that is an option if we need a sterile specimen. Okay.
Okay.
Now, for infants, to get their output, like if we need to calculate urinary output, if they ordered eyes and O's, then we weigh the diapers. And then you'll see usually in most pediatric units, they'll have the size of the diapers up on the wall and how much the diapers themselves weigh, because you have to subtract that obviously from the output.
Oh,
So
yeah.
you weigh the diapers, subtract that diaper
The weight of the
weight,
diaper.
and then you put that in the output. Okay. All right. Now we're going to go right here to collecting urine. Okay. So, and this is these standards will hold across everything. When you're collecting anything into a cup and it's a culture, the inside of the cup is sterile. That means nothing should touch the inside of the cup. Okay.
Okay.
The
Yeah.
outside of the cup obviously can't be sterile,
Right. 'Cause you
but
gotta
the
hold it.
inside of the cup is. So, like if somebody's collecting urine, they shouldn't hold the cup to their skin. You've just contaminated it, right?
Yeah.
Their
Yeah.
fingers, nothing should touch the inside of the cup. Okay.
Right.
You always want them to clean the area first, of course. Okay.
Mhm.
And there are special urinary cleansers that we use for that. Okay.
Oh,
We don't,
oh,
no
oh.
alcohol. Somebody said that one time, and I'm like, can you imagine how
Mhm.
bad that would burn? No, there are special ones that do not burn. Okay. So a clean catch urine is actually misleading because it is the dirtiest type of way to catch it, because you send somebody into the bathroom, right? They
Right.
clean themselves. I don't know how well they clean themselves,
Right.
and there's a certain way you have to clean. Like if you're a girl, you would have to open the labia and clean, like actually like where the urethral orifice or the hole is. A lot of people don't. They just wipe like they would with toilet paper, right? And
Yeah.
so when the urine comes out, like you said, it touches the skin on the outside. It's really no longer sterile. So clean catch is actually the dirtiest way to catch it. Now I would use that if I was doing like,
But that's like what
that's how they do
yeah,
it. Yes,
but
that's the
isn't that
standard
like
right now.
most likely when you get they ask you to clean a cup? I mean,
Yes, that's what they do. So, but because of
and
that,
that's called a clean catch.
it's
But
called a
it's
clean
not
catch. It
wet.
should be called dirty catch because it's gross. But there is a specific amount of bacteria that has to be present in each of these in order to say it's an infection. So,
Oh.
because a clean catch is so dirty, there would have to be greater than 100,000 CFUs per ml of bacteria before I would say that it's a UTI. Okay. Our sterile option would be a straight cath, right? So that is sterile technique. We are cleaning with iodine. We put it right into the bladder where the urine is still sterile, right? And we collect a specimen that way. I only need 50,000 in order to say that that is an infection because it should be
Now
considered
that
sterile.
sounds painful.
Yeah, that's not fun. Okay. And then there's a Foley cath. Now, to me, Foley caths are dirty. It is a sterile specimen. It is still considered a sterile specimen. The reason why I think Foley caths are dirty is because I have never seen a nurse actually provide perineal care when a patient has a Foley. You're supposed to wash it every day
Because you can
because bacteria can travel right up that tube and
that's
right.
how people
Oh,
get
yes.
UTIs.
Foley caths are notorious for causing UTIs, right?
Right.
So we don't want to put on a Foley cath
The
unless you
Foley is
absolutely
kinda
have to.
like that's like a last resort.
No, they put them in everybody. It should be a last resort.
But oh, just for convenience?
Yes. And that's the thing on an exam, and this is for all of nursing too, you should know like Foley's are never for convenience. So just because somebody is incontinent, I am not putting Foley in that patient because I'm putting him at really high risk of UTI. If they're incontinent, we can put him in a diaper. We can put chucks underneath. We can use a PureWick. Have you seen a PureWick?
Yeah, that's interesting because when I had my hip surgery,
Mm-hmm.
they used a Foley catheter because I couldn't, not because I couldn't get, well, I couldn't
Well, you
get
couldn't get
up.
up
I
at
couldn't
that
get
point.
up,
But there's something called a fracture bedpan they could have used. So a lot of times it is for convenience.
yeah.
And it should not be that way. So they may ask you a question like, what's the best way to prevent infection in a patient with a Foley cath? Take out the cath. Right? So every day
Okay.
you should be assessing, do they still need this? And the only people that absolutely have to have Foley caths are people that cannot void on their own. It is impossible for them to void on their own.
Okay.
You could avoid it on your own. right?
Probably.
Yeah. Now, unless it was right after surgery. Now, right after surgery, sometimes
Well,
you
unless
can't.
I think there was a point where like I felt like I wanted to pee, but nothing would come out.
Okay, well, in that case, I would have straight cathed you. Okay, so you can always straight cath the patient because the likelihood of infection is less. I could put the cath in and pull it right back out, right? So allow you to void and then wait a couple, and in a couple hours, your bladder tone may have come back because the anesthesia wore off, right? So as a nurse, you get to choose what you want to do, right? But a lot of nurses, and I get it, they are busy, you know, but a Foley cath is such high risk of infection that we want to get it out as soon as possible. Okay. All right, and then if we want the most sterile way to collect urine, we will do a suprapubic aspiration. So let's say a patient has a super enlarged prostate, all right, and the prostate wraps all the way around the bladder neck, okay, where the bladder comes down, and it wraps around the urethra, okay? So here's the urethra, the tube that gets the pee out, right? And the prostate wraps around like this. So if you have an enlarged prostate, your urethra is closed. Nothing's coming out. And even if I try to cath this patient, I can't because the prostate has closed the urethra. Okay. So if I try to cath them and I'm like, this is not going in. Okay. Well, we have to get rid. Yeah, because of the prostate is wrapped around it. Then we would take a large bore needle and we'll clean the area with iodine and you'll put a needle directly into the bladder and get urine out that way. Now, that is obviously the most sterile, but probably not the most comfortable. So it's not something we routinely use, but that is the only other way to get out urine if you can't get a cath in. Okay. All right. So that's different ways that we can collect. Different nursing diagnoses you may see with urinary elimination would be, of course, impaired urinary elimination. That could be from literally anything, right? Either incontinence or UTI, it doesn't matter. You know, if something is wrong with your urinary elimination. Stress urinary incontinence. That's one we talked about where if you cough or sneeze or yep. Risk for urge urinary incontinence. So this is where you do kind of feel like you need to go, but it happens very quickly and you can't stop it. Okay. And a lot of times this will happen with either spinal cord injury patients or elderly clients. Okay. So this is a risk for that. Okay. Impaired skin integrity is another big one. Well, that one's functional. If you can't mobility wise get to it, but if you have the urge to go, but by the time you feel the need to go, it's already letting go. Right. So it's not a mobility issue per se. It's just, there was no time between. Usually we have time between. Your brain gets the message and like, you can hold it for quite some time. Right. But they can't do that. Right. By the time their brain gets the message, it's already almost too late. Okay. Kids do this a lot too. You know, I'm playing. And then by the time they realize like, I really got to go, it's too late and they'll have accidents. Right. Okay. Impaired skin integrity. Now we know urine is acidic. So if we're not doing very good perineal care, then they can get some pretty bad skin breakdown from urine. Lesions, pressure ulcers, just skin breakdown from it being acidic and sitting in a diaper. Okay. We see this a lot in nursing homes. Yeah. Let's see, toileting self-care deficit. So that may be that the patient can't get to the toilet. It may be that they are not able to wipe appropriately because they have some kind of mobility issues, right? There's something about they can't do their own self-care, so they either can't get to the toilet, they can't take care of hygiene after the toilet, something like that is preventing them from toileting appropriately. Okay, and then we've got nursing care right here. So your job is to help the patient to the toilet at regular intervals and give yourself plenty of time to get them there. Because remember, some people may feel the urge and have to go very quickly. Okay. Make sure you provide privacy for the patient because it is very hard to pee when someone's staring at you. And I know like you're helping them to the bathroom, but like I've seen a lot of nurses just stand in front of the toilet and wait. And I'm like, somebody's just like, you can't go to the bathroom. You know, but you have to tell them like, I'm right outside the door. Do not try to get up without me. Yeah, you have to just let them know. Encourage intake. Yes, leave. I know. So sometimes, and people don't always realize it. Like I see this a lot with CNAs and things like that. You just have to let them know, like, hey, you don't want anybody staring at you peeing. And it's hard to initiate pee when someone's like looking at you, so give them some privacy. Encourage intake at least 2 liters. Okay. Do very good perineal care. And that's just cleansing the area at least once a shift with soap and water, right? Eyes and nose and daily weight. Remember, daily weight will always trump eyes and nose. That's a better indicator of fluid balance than eyes and nose. Right? Okay. All right, let's go right here to health promotion. So if they ask you what are some things that you can do to help a patient with their urinary system, right? Tell them you need to go when you feel the need to go, because the more you hold it, the more your bladder stretches, and you can actually wear your bladder out to where it doesn't feel the need to go anymore, right?
Is that what happens if you hold it
That's what happens to
so?
nurses. Yeah. Nurses are notorious for having bladder issues because they may have to wait 4 or 5 hours before they pee. So nurses get a lot of UTIs, plus they can't drink at the nurse's station, right? So they're dehydrated, right?
Yeah.
And then they can't go when they need to go because a patient needs a med or a patient, So when you need to go if you're able to do so. Decrease any sugary drinks or anything that's salty, like even Gatorade is not good for you. Like that's kind of a salty drink, or any
What about
salty
like
foods.
Propel?
Um, if you want my personal opinion, okay. I don't think any of those drinks are very good because they add so many extra chemicals to them. You can just add salt to your own water. I add salt to all of my water. All right, I put salt and I put lemon in it. It's like a tequila with.
Really?
Yes, because our body has to have salt,
So
right?
how much salt you put in?
Just a pinch. I use Celtic salt and I just put in a pinch with every, big one like this that
Yeah,
I drink.
'cause I put lemon in my water.
Because if you drink straight water, it actually dehydrates you because it waters down your sodium, right? And then your body tries to retain water, right? So the best way is to drink a little bit of salt water. That's how our body's meant to be, right? We're made of salt water. Like when you bite your lip and you get blood, what does it taste like?
Yeah,
It's salty.
yeah.
We're made of salt water. So if you're drinking a ton of water, then your kidneys get the message, hey, we're too watery and I need to pee more. So it can actually dehydrate you if you just drink straight water. So I always
That's
recommend
very
a little pinch of
interesting.
salt with every drink that you
So
make.
not like a whole teaspoon.
No, don't die or anything. Now, if you have hypertension, of course, take that with a grain of salt. Okay. 2 to 3 liters of fluids. I told you that. All right. Clean the perineal area. And that's not just when they're in the hospital. You need to encourage them to make sure that they keep that area clean, right? But with women, there's a whole market out there of vaginal deodorants and douches and all these things. Your body was not meant to withstand any of that. Okay. So
Right.
you're not supposed to use any of that. So no douches, creams, deodorants down there. You don't need any of that. It alters your microbiome. We have an entire bacterial microbiome in the vagina. It's meant to have bacteria in there, right? It's a mucous membrane. It's just like your gut, right? And so when you're introducing things like douches and all of those kind of things, it alters that. And so your risk of getting yeast infections and UTIs is way higher. Okay.
Yeah, that happened to me when I was doing bubble baths.
Oh, bubble baths are
They
notorious
said,
for causing
they said, no,
UTIs.
don't do it.
Yeah, it's just irritating. Like the vagina is a very sensitive area, right?
Yeah.
And so it's not meant to withstand that harsh of chemicals. So
Right.
even like laundry detergent and things like that can be irritating and cause UTIs. Okay.
Oh, so it's probably best to get the stuff that's
Chemical free.
free of.
Yeah, anything that has a smell has alcohol and chemicals in it. That's the only way that they can keep the smell, right? So you're not supposed to have anything that has a smell down there. Just soap and water is fine, right?
Okay. Yeah.
Daily Kegels, we talked about that as well.
Yeah.
Yes. All right, and then right next to that, right here, the goals for our patient that for our urinary system. So we want their urine output to be at least 30 an hour. Okay, we need fluid and electrolyte balance. The kidneys are responsible for that, right? So we want to make sure those are balanced. Free from any infection, that when they go to the bathroom, they empty the bladder completely. And remember, we can accomplish that by telling them to bear down as if they're having a bowel movement after they feel like they have emptied their bladder. Good self-care, meaning they're able to get to the toilet by themselves, they're able to wipe and perform their own hygiene. They are continent of urine, of course, and that we maintain their skin integrity, okay, by making sure we do good perineal care. Okay. And then right over here, I added 24-hour urine because I've seen a lot of schools test on this. If you're doing a 24-hour urine collection, because earlier when we talked about labs, the BUN, the creatinine, the GFR are all blood tests, and you're just doing that at one moment in time, right? So if we want to see how well can your kidneys do this over a 24-hour period, I need more of an average rather than just one point in time. They will order a 24-hour urine. And you can collect anything in the 24-hour urine. You could be looking for protein. You could be looking for creatinine clearance. It depends on what they're looking for. But they want to see over time how well your kidneys are able to do that. So you will find a big, giant, dark jug, and that's how we collect the urine. Okay. It is kept either at the bedside if they have a bedpan or urinal or whatever, or we keep it in the bathroom if they're able to toilet. Okay. But every single urine has to go in there. No, the jug goes at the toilet side, like at the next to the toilet. And they can either pee in a potty hat or they could use a urinal. Oh, I see. And then we dump it. Yes. So you could go in the potty hat and then transfer it over. If it's a male, we can use a urinal. If it's a female, we could use bedpan, So however you want to collect it is fine, but every single urine has to go in there because if we miss even one, then it's not an accurate depiction of 24 hours, right? So you need to post a sign on the door and a sign above the bed that says we're doing a 24-hour urine collection. So that way when the CNAs or UAPs, whatever they want to call them, come in to do eyes and O's, they know to collect that and put it in the jug rather than dump it. Like if they come to empty the Foley or something like that. Yes, a lot of times it's for kidney problems. Yes, because protein, BU, and
Yeah.
creatinine, those are all kidney labs.
Yeah.
You will set a time to start. So you'll put on the sign 0900. Okay.
Yeah.
Now you can do it one of two ways at that point. You can either say at 0900, you need to go void, and we're going to discard that one because I want to start fresh and new because I don't know how long that has been sitting in your bladder prior to 9 o'clock. Right. So you can do it that way. Or you can say, hey, we're going to start at 9 o'clock. And then the next time you have to void, we're going to dump that one. Right. Because I don't know how long that's been sitting. And then we need to collect every single one after that. Most of the time, they'll set a time and ask them to go void at that time. Or if they have a Foley, that's easy to do because you can just empty the Foley at 9 o'clock
Yeah.
and then we started, right?
Yes.
But if they miss even one, you have to start over the entire thing. Okay. So that's why we put signs everywhere because nobody want to miss anything because the doctor's going to be mad. Okay.
Yeah.
So have the patient empty the bladder. You discard that one right when it started. Okay. And then if anything is missed, start over the whole thing. So that you need to be very clear with the patient. Don't throw away your urine.
Don't flush.
Yes, do not flush. Okay. Or you can flush because there's a potty hat in there, but stop it. Okay. Do we understand the basics of the urinary system?
I think so.
All right.